give it another couple of minutes, then we can start. Oh, hi, Charlotte.
Hi. Hi, apologies. I've just come straight from a Raw Free interface meeting. Sorry to be like a couple of minutes late.
No
Hi,
problem.
everybody. Should we make a start?
Yeah.
Thanks, Anisha. Apologies for that. Hope I didn't get your blood pressure racing too high. Nice to see everyone. I hope you had a nice bank holiday weekend, and thank you to those of you who've been vaccinating, and those of you who got a chance for a bit of a break. Hope you enjoyed the glorious sunshine. Really pleased to carry on being at these Barnet events that we don't do across all the different boroughs in NCL. So I think it's a real testament to how we come together well as CCG and with the Federation and with the Training Hub, and really many thanks to the Training Hub for the admin support and bringing these together. So we're going to continue to hold these events on the first Wednesday of the month. Emily from the Training Hub is going to be posting another link for the poll, including suggestions for topics. So many thanks to those of you who completed the poll in May, and to ask whether people would like, if we're able to, subject to COVID restrictions, if we're able to do a face-to-face Barnet event in October. So if we're able to do face-to-face, whether we'd like that, assuming that we're able to with COVID restrictions. So if you could put in the chat, that would be incredibly helpful. Thank you. Sorry, I didn't actually introduce myself. I think I know most people. So Charlotte Benjamin, I'm a GP from St George's Medical Centre in Hendon, and I'm Vice Chair of North Central London CCG, and I'm on the CCG with Claire Stevens. We're joined today by Lena Mystery, who's the Medical Director from the Barnet Federation, Fra Abio Bolushudan, who's the Integrated Nurse Team Lead from the Rapid Response Team, and they're going to talk to us about a service update, reminding us about the referral criteria and the positive impact of having direct GP input into that system. We're then also thrilled to be joined by Sue Laurent, who's a retired paediatrician who many of you know, a medical director of Noah's Ark Children's Hospice, who's coming with Lindsay Davidson. And I've seen their video, it's brilliantly done. Have your tissues to hand, because it's very emotive, but very well done. So looking forward to that. I was also asked by Anisha, just there was a request to have a bit more information about integrated care partnerships, ICPs and ICSs. So new words that have come into the system that sound fairly similar, but they are actually going to be have a huge impact on our working life going forward. So integrated care systems, or ICS, is what we're looking to move to in North Central London. So in London, we have 5 of these, North Central London being one of them, where we have about 2.3 million residents, made up of the 5 boroughs of NCL. And this is looking at working.
Hold on, Charlotte, you've been muted.
Okay.
Sorry.
Thanks for flagging that. Can you hear me now?
Yeah, we can hear you, Charlotte.
Thank you. So across our 5 boroughs, we're looking at working, instead of having commissioners and providers, so providers being primary care, the acute hospitals, mental health, community, also working with local authority and voluntary sector. We're looking at bringing that together as a system to do much better working. A, to be more proactive, working to do much more preventative medicine for patients, and also B, to look at the where patients who've got chronic conditions struggle is the interface between the different parts. And I've just been at the interface meeting with Royal Free, been discussing a lot of the issues that we're struggling with. And one quick win that we're hoping to sort out that we've just discussed is getting rid of the stopping consultant to consultant referrals. So if a clinician sees somebody in secondary care and says they need to get seen by another body, instead of asking the GP to do that, we're looking to reverse that. So there's lots of bits of the system that are clunky, and hopefully working as an ICS across the 5 boroughs and NCL at scale will help. Separate to that is also ICP's integrated care partnerships, and that's looking at working at local levels, so Barnet being an integrated care partnership. And working, we already have a board that comes together with providers, the Federation, the PCNs, the Royal Free, Mental Health and CLCH, and looking to system solve for patients in Barnet, and a lot of really good work's been done. And then the key is also neighbourhood level, which is our primary care networks. And we know hugely successfully over the last few months we've done COVID vaccination, and if you'd asked anybody a year ago would we be able to do that, we'd have probably said no, it would take too long to sort out. But we rose to the challenge, and you all rose, and in your practices and with your practice teams rose to the challenge, and actually vaccination's been a huge success of PCNs working together, and these working together as part of an integrated care partnership. So that's a bit of a quick rush through, and there probably isn't a huge amount of more time to go into more detail, but Anisha just thought it was helpful because these are some of the questions being asked, just to familiarise ourselves with some of the issues that are going to be hitting us. And the integrated care system is looking to be mandated to form our system in NCL by April next year, and looking to go into shadow form from October. More legislation is due out in the next few weeks, which will hopefully give more clarity to that. One last thing just to say is where we're doing well in NCL is we have a GP alliance, which is where different GP providers are coming together to actually have a singular voice, bringing that voice of general practice to be able to communicate with the rest of the system and the other providers. I'll put my address in the chat. I think most of you know it, but if you've got any questions you want to ask, any specific questions, more than happy to answer them. So I'm now going to hand over to Suzanne, who's going to give a medicines management update. So many thanks. Over to you, Suzanne.
Thank you very much. Hopefully my slides will pop up. But first of all, before I start, I just wanted to let you know some medicines optimization team updates. The first being really exciting news that Meninda Kaur Singh has joined us from East London, and she will be the new head of medicines management for Barnet Borough. So we welcome her and very excited to work with her. Also, a small update of our team is Sejal Ladd has actually been appointed as a care home pharmacist, working with Cynthia Agbinyegar, who I'm sure many of you know. She's going to be working on the care homes, and any of the practices that Sejal did support, we will be reallocating within our team. So you won't, please don't worry, you won't miss out on a support pharmacist. Next slide, please. I thought it would be good to just make sure that everyone's aware of the access to end-of-life medications that are in across North Central London. There are 22 community pharmacies that stock sort of core end-of-life medications like lycopyrronium, haloperidol, morphine, sulfate, midazolam, and these pharmacies do stock this list, which has been agreed with our local palliative care consultants, and in a list of the pharmacies with their opening hours and actually EPS codes, so you can direct them, is actually on the NCL GP website. You can find it under prescribing guidelines, or if you just put in the search tool end of life or EOL, it should come up. Or even community pharmacies, it should come up there. And also we have a link on ScriptSwitch for the medications that are included in the call list. There is a link on ScriptSwitch to these community pharmacies. If you have any problems in accessing any of these medications, please do let me know. This is for the community pharmacy service, and it's actually access in usual business hours. So it should cover all of your any of the primary care clinics because it's open Monday to Sunday. Next slide, please. So we have launched the NCL Prescribing Watch, which is very exciting, and this is really a wonderful cross-borough work with all the boroughs coming together to contribute into this. Hopefully you will have seen it, and if not, it's being sent to all practices and practice managers. If you're having an issue and you haven't seen it, please let us know and we'll try to sort out the access for that. And our email address is at the end of the slides. One of the more notable where we have had quite a few queries is chloramphenicol eye drops, which are now contraindicated in children less than 2 years of age due to the content of the boron content, which apparently can lead to infertility issues. Although I do add that I don't believe there have been any links to date, but these are now contraindicated, so shouldn't be used. The ointment is not contraindicated, so can be used. We have the next slide, please. One of the other areas which we often get a lot of comments is upgrading to Freestyle Libre 2. Freestyle Libre, if you want to upgrade your patients who are on the Freestyle Libre 1, you can do that as long as you think the patient is going to be able to look at the supporting documentation and learn about the new upgraded Freestyle Libre, all the developments that it, all the features that it now contains. If that's the case, then you can go on the NCL MON website or GP website for a flowchart, and this flowchart is also linked to ScriptSwitch, and this gives you the webinars and tutorials and order how they can order their replacement reader if they need it. So it should give you all the information in one place. Just wanted to point out that sterile swabs are no longer included with Freestyle Libre 2. But they are still required. Patients still need them to wipe off the oil on their skin before placing the sensor. So if you do get pushback from patients, in the leaflet from Abbott, it does suggest patients buy these sterile swabs, but if you do get pushback, they can be prescribed, and about £1.80 for 100, and a pack of 100 should last about 3 years, shelf life permitting. Very important to avoid waste, so please make sure patients use up all their existing. And also, I wanted to say that if a sensor, patient should only be getting 2 sensors every 28 days. And if a sensor fails or malfunctions, then the patient should contact Abbott for a replacement. And on the ScriptSwitch message, there is a link to the frequently asked questions you can give to patients so that they can request this from Abbott. They'll have all the details there. Next slide, please. And that is our Barnet Medicines Management Team contact details. So if you have any comments or questions, then we'd be very happy to answer them. And I think that might be my 4 minutes up. Thank you very much. Lovely to see you.
Brilliant. Thanks so much, Suzanne. That was extremely helpful as always. It's good to hear about your prescribing watch updates that will now be circulated. And thanks for clearing up about the Freestyle Libre 2, because I certainly have had a few queries about that. So thanks so much. I'd like to hand over now to Dr. Sue Laurent, who, as everyone knows, is a retired paediatrician in Barnet, has worked in Barnet many years, and is currently a director at Noah's Ark Hospice and a DME in Barnet, and Lindsay Davidson, who is the commissioner for the hospice as well, and they're going to tell us a bit about their service. So Sue and Lindsay, thanks so much, and over to you.
Thank you very much. Is Sue around? I can't see her. Is she part of? Are you here, Sue? She's not in the Ark with me today, but maybe I just want to clarify one thing. I'm actually the finance director and in charge of commissioning for Noah's Ark. So I'm not actually a commissioner, but I look after commission work in the Ark. We have a little PowerPoint presentation, but we thought just because we've got such a short slot, we might not go through it, but just leave it with you for afterwards and just talk to you to introduce our service, and to explain what we do very briefly. Also, thank you for having us today. Thank you to Dr. Leora Harvard and Anisha for organising this for us. Do you want to play our very short clip just to start with? And then we'll follow up.
Yeah, Sam has that ready for you.
The moment I left my son with someone who I trust for first time in 14 years.
The moment that we came to the Ark gave us freedom.
We've been trapped in the house for 6 months, and going to the Ark just felt like I was finally free. It was honestly the best time of my life.
My paper didn't explain at the Ark. And
I like watching films with the Noah's Ark staff because they're nice to me.
The moment the NHS contacted us saying they desperately needed us to help out.
And the whole team put their hands up and said, we're in.
The moment we walked through the door, it felt like we were at home.
The moment the first child stayed at the Ark.
The moment my brother Francis was the first child to die at the Ark.
The moment a mom took time out to thank us, despite not going home with her child.
And a carer reading to a child who just died, waiting for his parents to arrive. Moments that make you stop and remind you why you're here.
Life without these moments that matter is unimaginable for London's most unwell, babies, children, young people and their families. Without the amazing work of our outstanding care team, this wouldn't be possible. We are trying to recruit more nurses and carers to continue changing the lives of these children.
Thank you. So can you hear me?
Yeah, we can hear you, Lindsay.
So that was just a couple of minutes from one of our campaigns during COVID, but it just gives you, I think, a feel of some of the children who we look after in the Ark. We are London's newest children's hospice. We sit on a beautiful nature reserve in Barnet, so we are literally behind the Spires shopping centre. We're very close to you all. We work across NCL and we very much have been hearing about the ICSs actually, and we very much want to be part of that, so please include us. We're different to adult hospices in that our children come and go. We offer much more than end of life. It's half term this week. We've got lots of children and their siblings running around in the Ark doing all manner of activities. We have a holistic approach to children, so we put them at the centre of everything we do, and each child we try and give a bespoke package of care depending on their needs and what the family want. Our referral criteria are very strict though. We only accept children who are life limited or life threatened. And our children actually are from the ages of 0 to 19, so we accept babies and children up to the age of 19. And actually yesterday in the atrium, which is the centre of our Ark, we had a graduation ceremony for a child who's now 19, just reached the age of 19, and is moving on to adult services. So that was very special yesterday. We follow the 6 ACT criteria. And we are very strict about that, and I've included them on the back page of our presentation, which you'll see, so you can see exactly the type of children we accept. We have a real specialism which we've developed with our nurses and specialist carers in neonates and children who are long-term vented, and we do some amazing work which we can discuss at some other time for both these kinds of children. And we really want you to refer children to us. We understand that not much of your caseload is very complex children and children who are at end of life, but there do seem to be a lot of them across North Central London, and we really want to take them from diagnosis, from the start of their journey. We want to provide care until they reach end of life, or until they move to adult services, or if they're, oncological children, until they don't need us anymore. But we just want to say, don't wait until end of life. We can support much earlier on. And lastly, just to say, we've opened a cafe and we'd love you to come and visit and come and have a coffee with us. It doesn't have to be formal, but we'd love to give you a tour. Can be long or short. You'll meet Sue if you come on a Wednesday, and the rest of our medical directors and our nursing staff, who are just amazing. We had a child this week, a compassionate extubation, and the parents just wanted to take the child out onto the nature reserve, and using our cooling technology was something we could facilitate for them. So it was just a very special moment that we had actually on Monday. So please just come and see us, refer children to us. We look after the whole of North Central London and sometimes beyond, children from Hertfordshire, children from North West London, CCG. So we'd love to meet you in person at some point. I don't know whether I've got any time for questions, but if anybody has one, or send me an email or call us.
They can post it in the chat. So thank you so much, Lindsay. I think Sue was going to join us from Kew Gardens today, but she's obviously she's clearly found some distractions, which is very good. Good news. But Sue will be joining us again in August for a full paediatric meeting. So thanks, Lindsay. That was really useful to hear about your service, and a good reminder that you're there for referrals. So thank you so much. I'm really happy now to hand straight over. If you have any questions for Lindsay about the hospice service, then please do post them in the chat. But now I'm very happy to hand over to Dean Neumark, who is an elderly care consultant at the Royal Free Hospital. And we're very happy that he's joined us today to talk about the subject of falls, which is obviously a very, very common topic, and we thought that would tie in nicely with rapid response. So Dean, thank you so much for joining us, and over to you.
Okay, thanks, Anisha. Have you got the slides are coming up, I guess?
Yeah, they're on now.
Okay, thanks for the slightly late invitation, but welcome anyway. Thank you, and I have to say how amazing it is to see this sort of the hospice services that are available for children. It's really humbling to see what great work people do in the community. So moving on to slightly older, although not necessarily the very old, because falls happen to everybody under 65 and over 65, although obviously the over 65s is the group we tend to focus on. It's not going to be a long talk. I was given about 15 minutes. I actually can't speak for much longer because I have to go to clinic at Finchley, which has just restarted today for the first time in about 15 months. That's very exciting, maybe. Fine. So I thought I mean, everyone here is familiar with falls to an extent. So I just wondered, I thought, what can we do to make it a bit more exciting? And I thought I would discuss with you a recent New England Journal paper at the end, mainly because the results are possibly not as expected, but this was published in the New England Journal back in November, and it involved a trial which was conducted in this country by GP practices, so it's very relevant. And probably is more food for thought than anything else. But I don't know if anyone had a chance to read it last night. I'm sorry for the last minute, but I think planning my talk was a bit last minute. And then there is a we probably don't have much time to focus on. There is a new proposed NCL pathway for sort of streamlining falls, and I think the rapid response service may have something to do with that. But we all see falls, and sometimes you wonder what we should do with them. So I thought some of this should be by way of reminder, and if there are any questions at the end, I'm very happy to take it. The next slide. Okay, so this is probably a familiar sort of slide for you. Falls, there are over 400 causes of falls, which is part of the problem. And as we all know, falls in themselves is not actually a diagnosis; it is just a symptom. So we have to look for the underlying cause. But predominantly, the problem with falls, as we all recognize, is that if someone falls once, even if it is innocuous, it can trigger a cycle of decline. Not obviously in everybody, but that is the group that one needs to try to sort of recognize early to try to avoid problems from developing later. So the cycle is a reduced level of confidence, and then as a result of that, the person becomes more reluctant to move. and therefore they are less likely to exercise, and that causes loss of muscle mass. And as we know, loss of muscle mass creates a sarcopenic state, and they lose the muscles that you lose first are the thigh muscles and the pelvic muscles, and as a result, balance becomes a problem. And when balance becomes a problem, the rest is history. So there is increased risk of falling. The person loses confidence. They don't want to go out. They get more depressed. And as you probably recognize from this cycle and from my description of it, this leads to frailty. So obviously, people who are frail fall over, but frailty and falls are synonymous. Just a fall can lead to someone who falls over may not be frail, but if we don't do something about it at an early stage when it's quite easy to do something about it, then frailty develops, and that's where problems really sort of start. So falls and frailty was one message. They're very much linked and together, but getting there financially, trying to stop them at an early stage is really what we want to do. And next slide, please. So this I don't know how easy it is for you to see on your screens, but this is again from a New England Journal paper published last year. It's not a paper, it's a review article on falls, very helpful, quite straightforward to read if you have time. Essentially, it stratifies people into three groups, which possibly I just wanted to spend a little bit of time going through, because I think this is where it helps people to decide in which direction you send them in, and this would of course help with the NCL pathway, if that is the way what the powers that be decide to be the best thing to do. So a lot of this everything in this slide should be things that we know, but this particular pathway refers to patients over the age of 65, and when they fall, you can ask them whether they've fallen previously, and whether fear of falling is present, because that obviously, once they have fear of falling, their mobility drops, and as a result, as I said, muscle weakness and all the rest of it. So then you can split them up. So did the patient have more than one fall in the past year or not? If they didn't, then that's more simple. This is, hopefully you can nip this in the bud. This is just it's likely, of course, it could be you have to take the rest of the history as well, because if there are some red flags, which I'll talk about briefly later, but otherwise you can sort of palm them off into trying to do prescribing exercise for them, or if there is a fear of falling, maybe a slightly more involved program, or a falls group or a falls class, which hopefully will be restarting, which everyone finds really helpful, and there is reasonable evidence that it helps. And we get good feedback from patients, and it gets them out and about, and so there's some social interaction. Hopefully, once COVID, once all that's sort of finished, well, hopefully. And then on the other side is patients who fall over, who have had more than one fall in the year, and that obviously is a bit of a red flag. Once is an accident, twice is probably less so, and so you would tend to obtain a greater history about the circumstance of the fall. Is it consistent with syncope? Well, if it is, then you send them down the route of the evaluation, either to a falls clinic or to a cardiologist or neurologist, or whatever sounds like the most appropriate thing to do. If there is no history of syncope, then a falls clinic may well be appropriate. But you ask some more questions about whether they've attended the A&E departments. It's always wonderful. I find that people seem to forget what they've done, and I think that's always a difficulty, especially as people get older and the history gets slightly vaguer. That's always a bit of a red flag. And then clearly in that group, one has to decide whether to go down the multifactorial assessment route or to just send them for an exercise group, depending on the findings there. So and hopefully that is helpful to an extent. A lot of people falls. 1/3 of people over 65 fall every year. So if we're going to send everybody down a route of exercise programs or whatever, we're going to get saturated super fast. Next slide, please. Okay, so just a lot of this stuff is well known. I just thought I'd put it on one slide to talk about important things. Well, the falls in the medical history we've just discussed, that we should ask relevant questions. I think the most relevant question, well, in fact, the most relevant thing is not a question, it's a fact. If the person has a head injury, then almost certainly they've lost consciousness. I find, as you probably do as well, that people do not remember, even if they say they've lost consciousness or not, I find that a lot of people do not remember accurately at all. So I think one has to make a judgment on that, whatever the patient tells you. The important assessing gait and balance, well, that is probably the most, between that and fear of falling, are probably the most common reasons for people falling over, and that relates to not exercising, lack of nutrition, social isolation. So all those things are very important in terms of falls. Postural hypotension is something we must never not check. And then the more exciting and sexy aspects of falls, including arrhythmias and cardiac problems, aortic stenosis, although that tends to be a very uncommon cause of people falling over, and whether people have had seizures as well. Often the most helpful question with seizures is whether they're confused after the fall. Medication review is something that's really important. The NICE guidelines suggest that up to a third of people may be on a drug that might increase the risk of falling over, and so therefore medicine assessment is always very important. Cognition, because unrecognized dementia or cognitive impairment could increase the risk of fall. They lack loss of safety awareness, making impulsive decisions, and often that can be a presenting factor for someone who has a cognitive impairment, because, as we know, with older people, they often merrily go along until something happens, but they could be merrily going along dementing and other problems developing, and no one is any the wiser until something happens. And this is our opportunity. Often the only interaction is with a A&E, with a London ambulance, or with the GP, or with the recovery team, rapid response team. That might be the only interaction, and so it's important to try ask a few questions regarding orientation. Is usually helpful. If someone is not orientated in their own home, then that is always a red flag. Incontinence is important to think about. Urinary incontinence, certainly, possibly to a lesser extent. Fecal incontinence is related to fall, probably because people rush to the toilet, and therefore, even if they have a good reason to, if you don't know that they're incontinent, they'll rush again, and therefore you can sometimes treat that and prevent them falling over again. Visual acuity, cataract surgery is actually one of the most successful falls treatments, actually. So there's a very high rate of improvement and reduction of falls after cataract surgery. Hearing is important, because not only is as one of the senses that helps us judge distances and balances, which is very important. Up to 10% of falls occur because of poor footwear. I'm never failed to be surprised by the really poor footwear when I go on home visits that people manage to wear. It's really amazing how poor people's footwear is. And as you might know, with the way feet are, if you look at someone's feet, you can often tell whether they're able to look after themselves or not, because if their feet are in a poor state of repair, then there is definitely a red flag there as well. Home hazard assessment is a gold standard, and bone health assessment obviously we don't forget that falls lead to fractures, and anyone who's falling on a regular basis, or even not, one should think about whether or not a bone health assessment is appropriate for that. So next slide, please. Okay, so just a few things about the NICE guidelines. I don't want to go into all of them, but in terms of multifactorial interventions, strength and balance training is certainly something that is recommended. It comes in different shapes and sizes, because you can do strength and balance training, and the Age UK have got a very good PDF download, which I tell patients to do. Whether or not they then engage with them is another matter. But doing Tai Chi has often been shown, certainly on the beach, is very nice. But Tai Chi does have a relatively good evidence base as well, similar to strength and balance for core muscles. Pilates, somewhat similar, and Otego dancing, and the exercise program is a series of strength and balance training exercises with a recreational walking program, which has become a little bit more popular now, and again has some evidence base that it may not be superior, but certainly is equally good in terms of preventing falls. The home hazard assessment and intervention has been shown in some studies to be of help. Vision assessment, I just sort of mentioned, cataracts, but glaucoma as well is quite important. and macular degeneration obviously is rife as one gets older, and as we know, we can do something about it. And then medication review with modification and withdrawal, probably the most tricky aspect of what we do with falls, because there is always a good reason why people have been prescribed medications. There are often some quick wins, but on the whole, it's that balance that is can be really difficult to actually judge correctly. But as 20 up to 23% in this study of over 75s were taking inappropriate medications. And as we all know, there are a lot of, I think 6% of admissions to hospital in the UK at one point were due to adverse drug reactions, or of which some of them were due to psychotropic medications and other medications, antihypertensives, which sort of also patients with cognitive impairment taking medications for diabetes. One has to be careful about what they take. And these are all very difficult areas. One could talk about them all day, but we're not going to. Okay, next slide, please. Okay, so just to finish off my talk, I don't know how many of you were able to read this paper. I haven't. Essentially, this is a paper published in the New England Journal in November of last year. It's a study looking at screening for falls and seeing whether interventions up front make any difference. So it was a UK-based study. I think it was led from the University of Exeter, but involved Coventry and Leeds. And what they did, there's initially they took 82 GP practices, I think, and then screened out 63 of them to participate in the study. 21 were in each group. What they did was the patients who are at risk of falls, they managed to recruit to the study patients by writing to them that if they wanted to participate in the study to look at older people's health. The average age of the population was 78. I think they looked at everyone over the age of 70. They split them into 3 groups. One group got advice by mail only, and the advice by mail was an Age UK leaflet about balance and falls. Then the next two in the other two practices, the other 2 groups, one group was given an exercise program. In terms of all groups were given advice by mail. Then in the 2 groups which were the intervention groups, there was a group. They then sent a further questionnaire to those patients that were recruited, and those and they had to fill out a further questionnaire about their risk of falling. And those patients within those GP practices that were deemed to be at high risk of falls, one group was given an intervention of an exercise program, and the other group was given a sort of all singing, all dancing, multifactorial fall prevention program. And by that I mean they were seen by either a trained nurse or a GP or a geriatrician, and they were given a home hazard assessment. They were given an exercise group if needed. They were given all the things we've described about looking at footwear, looking at vision, looking at hearing, looking at medications. They had lots of face-to-face interventions. So really everything you might think of as good practice with regards to falls, the multifactorial fall prevention group did. As you can see from the characteristics of the participants, they were quite well matched. They did frailty scoring in all of them as well, and that was quite well matched across the board. Next slide. So to cut a long story short, you might expect, obviously the expectation was that the group that had the all singing, all dancing, multifactorial fall prevention would come out on top. And we would have the main outcome measure. Well, the main outcome measure was number of fractures per 100 patients per year, and they were followed up for 18 months. And surprisingly, and possibly to the horror of those people who did the study, it came out that the group that had the highest number of fractures and falls actually was the multifactorial fall prevention group, and the one with the lowest was the advice by mail. They did a they did a cost analysis, and they found actually that the exercise group had the best cost analysis, because if you took the group of patients who were falling in that group, and if you look at how they improved, that was probably that came out on top as an intervention. But the big question is why is this the case? Why did the multifactorial fall prevention group not have the greatest reduction in falls? And actually, I have discussed this with some of my colleagues. I don't think this is a let's throw all the evidence in the bin that we've got. I think it does. Next slide. So this is my final slide. I think it does raise a lot of points about falls in general. I think the first thing it says is that just because you intervene doesn't mean they're not going to fall over, because you're dealing with a very difficult group of individuals that even if you do everything correctly, you'll still find that they fall over because of the associated frailty and other factors. Like with dementia, you do one thing, but there's so many things going on. It's a problem. So I think we have to think long and hard about who is going to benefit from which intervention. The authors of the study did find that in various Cochrane collaborations that have been done recently, although the initial evidence of multifactorial intervention is a great thing, actually they found on the whole that it wasn't possibly as helpful as one would have necessarily thought. So I think determining which patients are the right ones for this intervention is going to be very important. I think adherence is a problem, because if you look at the exercise group in the study, it's all very well doing all these things, but if the patients are not actually adhering, and we all know that is a problem, certainly also with comprehensive geriatric assessment, the studies have only suggested that even if you do a full comprehensive assessment of a patient, after 8 to 12 months, that sort of runs out unless there's some sort of follow-up, which will help. And I think that's going to be really important into building it into models of care going forward. The quick win is always going to be catching patients much earlier in the pathway. So that is why I say start younger. Are we looking at people who we know are going off? Are they in areas of deprivation? Do we recognize that this group is going to, do we want to try to do something from a public health view about trying to make sure that they get access to goods so they don't lose muscle mass, make sure they get exercise and nutrition, because that's going to be much cheaper and probably going to help more people in the long run. But I think, and this is where I'm going to leave it here, is that I think everything we do for falls is appropriate, and that there is good evidence, although the studies don't necessarily bear it up because of you just maybe the studies didn't choose the right people. It was all done by questionnaire. So, but I'd welcome any questions and any other thoughts about this. Thank you for listening to me.
Thank you, Dean. That was really helpful and a very useful reminder about footwear and vision and hearing. And I like your points about Tai Chi as well. So thanks so much for that. And useful to hear about the recent study. So Vijay Patel has posted in the chat a question about care home patients. So falls in patients who have dementia is common, and there's a lot of pressure from the nursing home managers given the recent care home DES. What's happening at present? Usually the referral is done, patient's discharged, and sometimes they recommend increased care package. Vijay, do you want to add anything to that, or is that more a question for the rapid response team, do you think? Or was like
Yeah, I think, I don't know if Dean remembers me, but we used to do a ward rounds together in Carlton Court, for example. And at that during those ward rounds, he would assess the patient, and a plan was put in place. So no referrals were done. Families were happy and avoided a lot of aggro. And I find this has become a little bit more intense now because of the DES. And just a lot of unnecessary trips to the hospital will start again. And these are patients who've got moderate to advanced dementia, and not much can be done other than increased care package. But the social workers, CQC, nursing home managers all want some statement from the Falls Clinic, and I don't know how to go about this.
Right. Yes, I don't. So these are care home patients that I mean, certainly patients in nursing homes probably don't need to be seen in the Falls Clinic because there's not a great deal that can be done in that sense, because by definition they're quite frail, very frail in fact. But residential home patients often fall over. Often they are in residential homes because the risk of falling is what's driven them into the care home in the first place, because they've been falling at home. I think one has to be very careful about again, this comes down to the history. Sometimes it can be useful to have a one-stop shop in the Falls Clinic, but just sending everyone who's fallen over in a residential home to a Falls Clinic when clearly the problem is impulsivity and loss of muscle mass and poor nutrition because of the dementia is not really going to help. So again, one needs to look for red flags, I think, in terms of, does there seem to be something else going on, or is this something that can be sort of managed within the home of a sort of a strength and balance group in the care home itself, which would be really helpful, good for social morale and mixing with other residents there. Looking at the body weight of the patient, or the resident, have they been losing weight, as I imply loss of muscle mass, which is the usual problem in this group, and is that due to the worsening dementia? So I think these things, I agree, the pressure only goes up with these things. I don't think the Falls Clinic is necessarily the most helpful place for a lot of these residents, and most of the information you'll have to hand in the care home. I think it may be helpful as part of the NCL thing is to have a discussion, to have a phone line discussion or a video link discussion with individual geriatricians, I think, rather than us visiting care homes. Obviously, that's not either time or cost efficient, but maybe advice would be really helpful, and that could cover a lot more ground. And I wonder if that could be possibly. I'm not actually involved in the NCL pathway greatly, but that's something that should probably be built into that.
Oh yeah, I mean, Dean, I'm not expecting you to visit patients. No, what I'm saying is that in the past we managed to avoid referrals because you were doing the ward rounds. Yes, we do have this NCL pathway, but I'm just wondering how to go about it. Just having some kind of direction or some sort of, something written down so we can give it to the nursing home managers. Like, look, because at the end of the day, there's this thing. While you're just a GP, can you please refer my loved ones to the Falls Clinic? The nursing home manager will also say the same thing, because they are now very much aware of this Falls Clinic. The
video, do you mean the written guidance for care home staff?
Yeah, I think written guidance is always going to be difficult with falls because there are so many causes of falls. But I think, as I say, the majority of them will be due either to dementia, loss of muscle mass, or sort of poor nutrition. And I think it's going to be difficult. But if one has some sort of forum which one could as I say, to give some virtual advice, I think now that a lot of things are done virtually, I think that would be far more acceptable, and that would be far easier to do a lot more of that rather than assessing them all face to face.
Thanks, Dean. That's a good thought. I think in the interest of time, because Dean, I know you have to go and Lena's waiting to present. We'll just take one more question if that's okay. Stephen Corcoran says dementia patients in care homes are very high risk of falls, get out of the chairs unpredictably and wobble. Any evidence for hip protectors?
Right. So with hip protectors, I think there was a New England Journal paper in 2001. I think it was either 2001 or 2011. It is the only journal article that I've ever seen that have actually shown any benefit of hip protectors. And so hip protectors are effective in that one study in care homes. They've never been shown to be helpful outside care homes, but there is some evidence for that. They have gone a bit out of fashion. The main problem is the laundering because they are. So you need someone that they take a lot of laundering, and therefore that's why we don't necessarily prescribe them. But there is a study that supports the use of hip protectors in care homes, and that is the only study in care homes.
Brilliant. Thank you, Dean. Thanks so much for joining us. Perhaps if there are more questions in the chat, I can email you, and I can circulate them later to the attendees. But thank you so much for joining us and making time for us in between your clinics.
Thank you. Bye.
Thanks, Dean. Okay, I'd like to hand over now. We are running a bit late, so apologies for that. To Lena Mystery, who's the medical director of Barnet Federation, to give us an update on the rapid response team. Thank you, Lena.
Thanks, Anisha. I'll be really quick, don't worry, because I know that lunchtime is probably pending for everyone. So we've got a short presentation. I'm going to be joined by my CLCH Rapid Response colleagues as well with regards to the Rapid Response support service that we've been providing in collaboration with the Rapid Response team. Can I have the next slide, please? So the service commenced in January 2021, basically as part of the response to COVID by primary care in the community. Particularly at that time, there was issues with LAS being able to delays in handing over patients and with rapid response getting through to clinicians for support and advice. And in response to that, this service was started, whereby we enhanced the 2-hour window where rapid response admission avoidance service was able to get in touch with clinicians directly, helping facilitate treatment promptly and providing care closer to home. There were GPs that were able to provide clinical care and management with telephone advice and also support with complex referrals. There was with EPS, we were able to sign prescriptions and send them directly to chemists locally so that patients were able to, again, obtain medication without delays. The service basically ran from 8 a.m. to 8 p.m. Monday to Sunday. So during those times, the rapid response team were able to contact GPs very quickly. Next slide, please. In hours, the service was provided by member practices. We went out for expressions of interest and then put together a timetable. The key with this was that there were named GPs that the team had direct contact numbers to, so could pick up a phone and essentially contact them very promptly and get advice that they required. After 6:30, that service was provided by our senior clinicians that also support our extended access service. And again, the team were able to directly contact those clinicians. I think one of the key factors that's been a success within this model has been the access for the clinicians to directly be able to use the emails to get information, but also write into the notes, which is real time sent to the GP practice. They're able to see what's been going on. And those discharge summaries were also shared with rapid response. They went onto their records. If I could have the next slide. I'm going to pass over to my rapid response colleagues now to introduce themselves and talk to you about their inclusion and exclusion criteria. So Abby, over to you. If you're on the call. Abby?
Hi there. Hi. Hi, so my name's Louise Archer. I'm the Clinical Business Unit Manager for the Rapid Response Team in Barnet. And really what we wanted to do today was just as a quick, I suppose, overview of the Rapid Response Service as it is, and looking at how we'd be able to work alongside the Federation as well to support ourselves. So as most of you will know, the Rapid Response Service is a multidisciplinary service that has been put in place to support patients, maintain them at home during a period of crisis, and able to respond within 2 hours, working alongside the patient's GPs to provide medical support, nursing support, and hopefully soon care support for patients to prevent a hospital admission. So I'm not going to go through all of the inclusion and exclusion criteria because I know obviously time is tight as well. But the key things to remember is that with the inclusion, we're looking at patients who are facing hospital admission today if they don't receive the support of the team. So we're looking for those patients who, as I said, have hit crisis. It may be exacerbation of a long-term condition or an acute exacerbation of an infection or chest infection, UTI, and things along those lines, falls, blocked catheters, all those sorts of areas that we will take these patients into under our care. There are some exclusion criteria, and those are patients that are primarily presenting with mental health problems, that if they pose a risk to either themselves or to the health and social care visiting them, and also patients who just don't consent to our visits. I think that's a key thing to say to people is many times we don't always, patients don't want to see us. So I think it's really important that when we're getting a handover from anyone that's referring to us, that the patient has been consented to a visit from the Rapid Response Team, and understand that we are a 2-hour response team, and that if you identify a need for them to be supported at home, then we will be responding within that time period. We've got a couple of case studies to go through, which I will hand over to Abby. So if we could go on to the next slide, please.
So good afternoon, everyone. My name is Abby Bolashodun. I'm the clinical lead for the Rapid Response in Barnet. So we have a case study number 1. Now, the patient was referred, referral was received from the GP surgery at 17:02. And the presenting problem was that 91-year-old lady living at home with her son, refusing hospital admission, and past medical history is hyponatremia, AKI stage 2, CHF, AF, mitral valve regurgitation, and diverticulation loss. And then the medication that the patient is on is spironolactone, bisoprolol, apixaben, Evercol D, which is for blood, for the bones, mirabetrogon, and laxidol. And following discussion with the treat consultant at Royal Free, it was advised that to have spironolactone dose and to monitor cardiac decompensation as diuretics reduced. Now, if patient develops shortness of breath, pedal edema, then needs to go back to bumetanide. Fluid restriction was, the patient was put on fluid restriction of 1.2 liters. Patient has low sodium, hence diuretic stopped. For review of weight and BP, etc. So rapid response clinician visited the patient at home at 6:30, completed a comprehensive physical assessment and observations. The patients appear very well, very well hydrated, no confusion, no lightheadedness. Observation were within normal range. So that's what the rapid response come up with. So there is a second case before.
Sorry, Abby, before you go on, just to say from the Federation point of view, the GPs that were supporting, the reason why we've highlighted this case was we were particularly able to help with regards to the past medical history and giving some background information, because obviously sometimes it's quite difficult to gain all of that from the actual referral. And again, the team, the rapid response team, were able to feed back to the GP once they've been out just to double check that they were happy with the plan. Sorry, Abby, I'll let you go on to the second case now.
So could I have this, the next slide, please? Yeah. So the second study was that the patient was referred, the referral was received at 09:37 a.m. Presenting condition was 94-year-old female living in assisted living complex. In the last 2 to 4 weeks, increased number of falls, bilateral leg swelling, likely dependent edema. The assessment was please assess for query UTI, and the past medical history is AF, depression, essential hypertension, and type 2 diabetes. So rapid response clinician visited the patient at home at 11 o'clock. We completed the comprehensive physical assessment and observation and urine dip. The patient was noted to have very oedematous lower limb with pitting edema to her knees. All observations were within normal range, and a urine dip was positive for blood and leukocyte. A urine sample was collected and sent for MS to the lab, and then we contacted the Barnet Fed GP for assistance with the patients. So I leave that with Dr. Lena to elaborate more on that.
Thanks, Abby. Yeah, so just to say that we were, this is where we've supported the team. We were called, we were able to look at the patient's notes, look at previous MSU results, and find the correct sensitivities for what she'd been treated with in the past, and prescribe promptly, send a prescription electronically, and the patient was treated with antibiotics. There were no delays in care, which I think was really beneficial. That's the end of our presentation. Happy to take any questions.
Thank you, Lena. Are there any questions from the rapid response team? I know that I'm aware we're running a bit over.
The only question, yeah. Can I go?
Yeah, go for it.
Yes. So the only questions that I can just ask the GPs that please could you just be mindful that when referring to the patient, we are not doctors as well. We are only nurses. So there are some patients that might have been referred maybe about 3 times or 4 times prior to another referral, and would come for the same problems. And we go there and it's the same diagnosis that we come out with. So in that instance, we suggest that maybe the GP might need to visit such a patient instead of referring them 3 to 4 times continuously to the rapid response. Mm-hmm. So I'm not sure whether that's
a useful reminder. Thanks so much to to think about what the actual issue is and whether they need a doctor visit instead. So thanks for that. Lena, can I just ask, with regard to patients, when you get feedback, because I, for example, often get calls from the rapid response team about patients that I've referred, I've referred to the rapid response team, and I want to hear back, so that's appropriate. But when do you, when would they call the Federation doctor in hours, rather than calling their own GP?
So I think the rapid response team have a lot of experience, and obviously if it's something quick, like they need a prescription for a UTI, they may well call us. I think they do try and contact the own GP, but sometimes they're in queues on, for the telephone, etc. So from their point of view, it slows them up and obviously takes them a lot longer. If there's complex patients that have, issues, so there was a patient who potentially was end of life, didn't have the DNARs, etc. in place, that is, we actually said that's something that needs to go back to the patient's own GP rather than someone that doesn't know them dealing with it. So I think it's the discretion of the nurse as to whether they feel it's something that we can manage, bearing in mind that we do have all the notes. In the majority of cases we can. There's only been a handful that we've asked them to refer back to the own GP, and we can close that loop with the GPs, because obviously we can create the discharge summary on EMIS that goes back into the practice EMIS, so they're able to see what the outcome has been of our consultation as well.
Mm-hmm. Okay, great. And probably the last comment, given that it's just gone 2 o'clock, Eugene Tang says, is assessment for UTI really very helpful? Better to give empirical antibiotics?
So I think that obviously if they've been referred, we will follow protocol and dependent on what the clinical scenarios appropriately prescribe.
Yeah, okay, great. Thanks, Lena. Perhaps if there's any other questions about the rapid response team that come up, I can email you, and
sure.
and perhaps we can communicate that via email.
That's great. Thank you.
Thank you.
Thank you, Lena. Charlotte, I don't know if we want to wrap up now.
Thank you very much, everybody. So we had over 100 people at the height of the meeting, so really great meeting again. So thank you. This is a topic, the focus on the elderly and falls is so hugely relevant to all of us. It's really good to hear about the interplay with the different services as well. So thank you really to the Royal Free Team, to Dean, thank you to to Abby and from the Rapid Response, and to Lena for the Federation support that you give to them. I think the Federation support to us has been absolutely excellent. Thank you to the Noah's Ark Hospice for the excellent talk and the video, and thank you to all of you. Right at the beginning of the chat, there is the poll for future topics that you want to cover, or you could just write it in the chat. For some reason, I can't access the chat, but I presume most of you can, because there have been posts being put up there throughout the meeting. The next date that we have a meeting is Wednesday, the 8th of July, and we're going to be hearing about the latest on pre-diabetes and also having an update on local fertility services. So we're going to try and aim again for the first Wednesday of a month. Again, if you have any topics, please do let us know. So hope that you have a good afternoon, enjoy the rest of the week, and hopefully there'll continue to be more sunshine, and we look forward to seeing you all again next month. And thank you to Lena and the team at the training hub for coordinating this, because they're great meetings, really enjoyable and really worthwhile. Many thanks. Take care.
Thank you. Bye-bye.
Thanks, everyone.